Hello everybody, I am Dr. Chetan Anchan. I am an orthopedic oncologist practicing in Mumbai. First of all, I would like to thank Professor Dr. Dominic Puthur for the invitation to participate in the 11th Basic Orthopedic Pathology course. I also thank the Amla Institute of Medical Sciences for this honor. I will be speaking on approach to a patient with suspected bone tumor. To begin with, you should know that the neoplasms can range from harmless to deadly, and therefore it is very important that you identify them correctly and treat appropriately. Treatment itself is not a harmless intervention, as you will see in some illustrative examples that I will share shortly. The need for treatment should be justified and it should outweigh its potential risks. Unplanned treatment of a malignant tumor can have life and limb threatening consequences, whereas overtreating a benign lesion could result in unnecessary loss of functional tissue. It is very obvious that any suspected bone neoplasm should be approached in a planned and systematic manner in order to manage it optimally. Case number 1. This is a 35-year-old gentleman with a history of fever along with pain and swelling in the thigh. His X-ray showed this destructive lesion in the femur which is permeative and really appears aggressive. It was reported as osteomyelitis on the imaging, and I would agree that osteomyelitis is a significant differential diagnosis in this case, looking at the pattern of bone damage and the fact that this patient had fever, pain, and swelling. Based on that, the surgeon went ahead and did a thorough debridement. And the final histopath report was Ewing sarcoma, and that is his condition now. He's got a huge swelling in the thigh. Along with that, he has got extensive metastasis. This patient succumbed to this disease in a matter of months. Case number 2. This is another young man who had a lytic lesion in the head and neck of the femur. Based on the imaging findings and perhaps based on the report on imaging, it was considered as a benign lesion in the head and neck of the femur. Most likely it was suspected as giant cell tumor. Patient underwent curettage, bone grafting and fixation. The curated material was sent for histopath and the final histopath report was high grade osteosarcoma, and you can only imagine what happens next. Case number 3. Here this patient had a lytic lesion in the lateral condyle of lower end femur. I assume the surgeon thought it is most likely to be giant cell tumor, which is a differential diagnosis in this particular location, probably in this particular age with this kind of presentation. So he decided to do an intra frozen section, which was again reported as a benign tumor by the pathologist. The patient surgeon went ahead and did a curettage and bone grafting. However, when the final histopath report came, it was reported as synovial sarcoma. Now in this case, the surgeon had taken bone graft from the iliac crest of the same patient, perhaps using the same instruments with which he did the curettage of the lower end of femur. Now this patient has a large local recurrence in the primary side, that is in the lower end of femur. At the same time, this patient has implanted sarcoma in the iliac crest that we can see on the bone scan, which was showing uptake at both these sites. So this patient, instead of having sarcoma in one location, now it has it in more than one location. So this is like causing iatrogenic metastasis. Case number 4. This is a young gentleman who had a destructive appearing lesion in the proximal fibula along with the adjacent tibia. It looked aggressive on imaging. The radiology report was osteosarcoma. The surgeon went ahead and did a Abani amputation. The amputated specimen was sent for histopath, and the final histopath report was no malignancy, rule out brown tumor. On further investigation, he was found to have very high level of serum parathormone, and a parathyroid adenoma was located in the neck of this patient. This patient didn't need any surgery for the bone lesion, he only needed the adenoma to be treated. So if only the right kind of workup was done here, this tragedy could have been completely avoided. So what do you want to know? Well, first is that you want to know whether there is a bone lesion in a patient. Once you know there is a bone lesion, you want to know whether it is a neoplasm. I mean, there could be bone lesions which are not neoplasms. Yes. So it could be osteomyelitis, it could be metabolic bone disease. These are not neoplastic lesions, but they can appear as neoplasms in the bone. Similarly, there are a lot of tumor-like conditions which are not really considered as true neoplasms, but for the sake of convenience, we label them as benign bone tumors. Now, if it is a neoplasm, you want to know whether it is a benign lesion or whether it is a malignant lesion. If it is a benign lesion, you want to know what exactly it is. By that, you get to know whether it is a latent lesion, that is a lesion which is just there, and most of these are incidentally found lesions like non-ossifying fibroma or a fibrous cortical defect. Or you want to know whether it is an active lesion, means it is likely to progress like a simple bone cyst, or whether it is an aggressive benign bone lesion like a giant cell tumor or aneurysmal bone cyst. Now, when it comes to malignant lesions, you want to know whether it is a primary malignant tumor of bone or whether it is a secondary in the bone, that is, some sort of metastasis in the bone from a cancer from some other organ, or whether it is a hematolymphoid malignancy. When it comes to primary malignant tumor of bone, you want to know what exactly it is, whether it is osteosarcoma, Ewing sarcoma, or chondrosarcoma. You want to know what is the grade of the disease, whether it is a grade 1 chondrosarcoma or a grade 2 chondrosarcoma, whether it is a low grade osteosarcoma. Besides that, you also want to know what is the stage of the disease. Stage of the disease means whether it is localized, whether it is locally advanced, or whether it is metastatic, means patient has distant metastasis or spread of disease to other organs or other locations. When it comes to a skeletal metastasis, you want to know what is the primary cancer from which this metastasis has come, whether it is a breast cancer which has spread to bone, whether it is lung cancer, thyroid cancer. So you want to know what is the primary source organ of that metastasis. Besides that, you also want to know what is the extent of the disease. That is, where else it has spread, how extensively has it spread, has it involved some other vital organs, whether there are liver metastases, whether there is brain metastasis, whether there is lung metastasis, if there are skeletal metastasis, whether this is a solitary metastasis or whether the patient has more metastasis, and what are the likelihood of having problems due to these metastases. And when it comes to hematolymphoid malignancies, you want to know what is the diagnosis, whether it is say multiple myeloma or lymphoma. Now, there are a few steps that are necessary for optimal management of a bone tumor patient. Most important is early detection. This really mainly depends on the patient, that is, how soon he reaches the doctor, and of course, depends on the doctor is how soon he realizes that there is a problem with this patient which needs thorough evaluation. Following that, the next important thing is to reach a correct diagnosis, following which this patient, if there is a malignant disease, has to undergo accurate staging of the disease, following which the patient should receive appropriate and complete treatment. Once the treatment is over, this patient also should maintain a very regular follow-up with the treating doctor. The most common presenting complaints of a bone tumor patients are pain and swelling. This swelling may be either a visible swelling or it may only be palpable swelling. Some patients may present with some form of disability, that is, they have a limp or they have some difficulty in performing certain functions, and that could be because of pain or due to mechanical obstruction of their range of movement. Some of them may present with a disabling event, means they were managing and suddenly they are unable to do certain activities, or there is a sudden onset of pain and deformity. This happens because of some form of pathological fracture of the bone. And finally, a significant number of them may come with an incidental finding on imaging. Specifically, this is very typical in children, where due to injury some x-ray has been done and they find something else in the bone which they were not looking for. Out of this, the swelling is objective, You may see it or feel it. Disability is also very easy to realize and assess. If there is a fracture, well, it is very, very obvious. Incidental findings on imaging are also quite easy because you can see them on the X-ray. Of all this, pain is a subjective complaint, and that is where we struggle to figure out what is going on. And a lot of the patients may be sort of neglected or not taken seriously, or their finding may be delayed because the common complaints of pain are due to some sort of injury or sprain. It's a musculoskeletal pain, but tumors also present with pain. So how do you really figure out? So this is very important, and therefore I spend almost 5 minutes at least on every patient in just understanding what is going on with their pain complaint. So take a detailed history specifically related to the symptoms, spend a bit of time on the patient's complaints, specifically when it comes to the complaint of pain. What you need to know is what is the duration of this pain? How has this pain evolved? Has it progressively worsened? Is it intermittent? Is it continuous? Is it constant? Is it mechanical? What kind of activities trigger it? What kind of things relieve it? How much is it bothering the patient? Does he need any pain medication? Does he have rest pain? Does he have night pain? Rest pain, night pain, constant pain. These are very, very important red flags to a possibility of the patient having a tumor. Also, a pain which is progressively worsening, pain which is constant, and earlier it was bearable, now it is becoming difficult to bear. All of these are red flags. You should take any of these complaints seriously. Any pain complaint of more than 2 to 3 weeks duration, it's an arbitrary number, but it is somewhere you have to, call it that this is important. So, any pain complaint which is of more than 2 to 3 weeks duration, which is constant, which is worsening, which is evolving, which is troubling the patient even at rest, and where the sleep is disturbed or where the patient needs pain medication are serious complaints, and you should investigate them in detail. Along with that, you should also know the duration of any swelling complaint and how it has evolved, whether it has increased over time. And if the patient has relevant imaging, you can also see whether this lesion has evolved on imaging. If the patient has any old x-rays and current x-ray, you can compare and see whether there is any change. Besides that, you should also ask any relevant past history, specifically related to a similar complaint in the past, or whether patient has had any history of tumor or treatment for any tumor in the past. Age is perhaps one of the most important clinical data in the evaluation of any bone tumor, and along with the radiographic findings, in a lot of cases you can almost reach to a diagnosis. Why? That is because a lot of these tumors come in specific age groups. You see, aneurysmal bone cyst, chondromyxoid fibroma, and chondroblastoma are typically seen in those below 20 years of age. Similarly, simple bone cyst, fibrous cortical defect, and non-ossifying fibroma are also diseases seen in the first 2 decades of life. Also, Ewing sarcoma and conventional osteosarcoma, these are two major primary bone cancers. They are also seen in the first 2 decades of life. Whereas giant cell tumor, one of the commonest aggressive benign bone tumors, are typically seen in skeletally mature individuals. Most of these are in their 20s, 30s, and 40s, and some even beyond. Whereas metastatic lesions, myeloma, lymphoma, and chondrosarcoma are typically seen in patients more than 40 years of age. Of course, you can see chondrosarcoma in younger patients also, but the majority are seen in those above 40. Chondrosarcoma typically you see in skeletally mature individuals. Next, we come to number of lesions. Some benign conditions often tend to involve multiple sites, like polyosteric fibrous dysplasia, enchondromatosis, multiple exostosis, Langerhans cell histiocytosis, etc. Whereas primary cancers of bone rarely present as multifocal disease. You rarely get to see multifocal Ewing's or multifocal osteo or multifocal chondrosarcoma. Multiple malignant lesions usually indicate metastatic disease. That means it is metastasis of some other primary, or you may see such findings in multiple myeloma or lymphoma. These are x-rays of some multifocal benign conditions. On the left, you see a case of multiple exostosis. You see multiple uh, osteochondromas around the knee. On the right at the top is a case of multiple enchondromatosis. You see multiple lesions in the small bones of the hand. And in the lower right, you see a x-ray of the pelvis with both hips of a patient with polyostotic fibrous dysplasia, which is showing extensive involvement of the pelvic bones and the left femur. You have a small patch even in the right femur. Here are some examples of primary bone sarcoma. From left to right, the first one is a case of osteosarcoma of the fibula, whereas in the middle you see wing sarcoma of one of the forearm bones, and on the right is chondrosarcoma of the humerus. In this slide, we see on the left a pelvis with both hips X-ray showing multiple sclerotic lesions involving practically all the bones, both the innominate bones, both the femur. This is a patient with metastasis of CA prostate. On the right, we see the X-ray of forearm and elbow with wrist of a patient with multiple myeloma, which shows multiple punched out lesions in practically all the visible bones. Next, we come to clinical evaluation, where you need to do a thorough local examination, evaluate the regional nodes, and do a cursory examination of the distal neurovascular function. In this particular example, it is very obvious where the swelling is. But in cases who come with only complaint of pain, where there is no visible swelling or palpable swelling, that is where your clinical examination becomes more important, because that way you can localize where is the pain coming from, which particular bone or which particular part of the extremity or which particular part of the joint the pain is coming from. That way you can narrow down your area of concern and advise appropriate imaging. When it comes to imaging, we have these various modalities at our disposal, starting with the plain X-ray, MRI with or without contrast, CT scan, and nuclear imaging like bone scan, PET CT scan. When it comes to radiology, it has got a very important role in the evaluation of bone tumors. First of all, it helps us in detecting a bone lesion. Besides that, in a lot of cases, it also helps us in reaching a diagnosis, or at least having a narrowed down differential diagnosis. It also helps us in staging the patient, both local staging and systemic staging. And finally, it also helps us in biopsy and treatment plan. Between the three modalities of local imaging available at our disposal, that is plain radiograph, MRI and CT, plain radiography is the single most important modality for establishing a diagnosis or differential diagnosis. A plain radiograph gives us a lot of information about a bone lesion. I am sure this will be covered later on in detail, but to briefly touch this topic, the information yielded by a plain radiograph of a bone tumor includes: one is topography of the lesion, that is location in the skeletal system and where exactly in that particular bone, which bone and where in the bone. The other things that you get to know is what are the borders of the lesion, that is zone of transition, whether it is wide or narrow, what kind of bone destruction it is causing, whether it is a permeative pattern of bone destruction or whether it is a geographic pattern of bone destruction, what kind of periosteal response it is eliciting, what kind of periosteal reaction it is eliciting, whether it is an interrupted periosteal reaction like a sunburst or a onion peel kind of periosteal reaction, or whether it is a solid periosteal reaction. what kind of matrix it is producing, whether it is a bone forming lesion, whether it is a cartilage forming lesion, whether it is a lighting lesion. And besides that, you also get to know what is the nature and extent of soft tissue involvement. Based on this, you may be able to decide whether you're dealing with a benign lesion or a malignant lesion. Benign lesions are usually well defined with sclerotic borders. They have geographic type of bone destruction and they display solid or uninterrupted periosteal reactions with no soft tissue extension. On the other hand, malignant tumors have poorly defined borders with a wide zone of transition. They may show a moth-eaten or permeative pattern of bone destruction with an interrupted sunburst or onion skin periosteal reaction, and a lot of them will show a soft tissue extension. It is important to remember that some benign lesions like giant cell tumor or aneurysmal bone cyst may also exhibit aggressive features. Now, based on your observations on plain ureograph and clinical evaluation of the patient, you may decide that you may ignore this particular lesion because it is clearly identifiable as a benign lesion, an innocent incidental finding on imaging. Most of the incidental findings on imaging belong to this category. These are latent lesions like fibrous cortical defect or small non-ossifying fibroma. In some lesions, you may want to observe because it does appear harmless and unlikely to be creating any problems, at least as of now, but the future behavior is not certain. It does appear innocent, but it can create trouble for this patient in the future, like some simple bone cyst or even a fibrous dysplasia, which at present is not really creating much issues, but the patient may have issues later on, and you would like to observe this lesion. And there may be some lesions where you would want to pursue it further because it looks aggressive, it is looking potentially aggressive, it looks like an active pathology, it looks like it might create trouble or it is actually causing trouble to this patient. In such cases where you want more detailed imaging of the patient, you may do advanced imaging like MRI and CT scan. These are imaging advances which have made the most profound impact on evaluation of bone tumors. MRI and CT scan are indispensable in musculoskeletal tumor staging. They give very accurate information about tumor size, location, and configuration, intra and extramedullary extension of disease, and relationship of the tumor to muscle compartments, facial planes, neurovascular bundle, neighboring joints, and organs. Between MRI and CT scan, it is the MRI which is the preferred modality of investigation for any musculoskeletal tumor. MRI affords more accurate anatomic staging than any other imaging method. However, it is very important for you to realize that it is not helpful significantly in differentiating a benign from malignant tumors. The most important role of CT scan in the evaluation of musculoskeletal tumors is primarily in the staging of this patient, that is, to do a plain HRCT scan of the chest to look for pulmonary metastasis, which is a standard investigation in the staging of a patient with a malignant primary bone tumor. Now, in all this, we should not forget the importance of chronology of imaging. It is very, very useful to compare recent radiographic studies with earlier images if available. Quite often, patients have relatively, a few months old or a few weeks old imaging, which is very, very useful for us to compare with to understand whether this lesion is evolving, whether it is aggressive, how it is evolving with time. Now we come to the pathology workup of patients. You may do relevant blood investigations where it is indicated. CBC and hemoglobin level workup is usually done for all patients. And besides, where you suspect the possibility of metabolic bone disease, you should do serum calcium, serum phosphorus, serum alkaline phosphatase, and serum parathormone levels. And you may do special tests like serum protein electrophoresis for multiple myeloma or specific tumor markers for specific malignant conditions. Next, we come to the very important topic of biopsy. Now, what are the indications for a biopsy? Well, all aggressive and suspected malignant lesions should be biopsied for confirmation of the diagnosis and documentation of the disease. In any situation where treatment is indicated and the exact nature of the pathology is unclear, you should do a biopsy. And where you have any unexplained active lesion, whether you are planning to treat it or not, you should do a biopsy to be sure about what is the pathology. Now, the question comes to who should do the biopsy? Well, it is clear that the biopsy is best done by the person who will be doing the definitive final surgery. This is important because the biopsy tract has to be excised and masked with the tumor at the time of definitive surgery, and therefore the treating surgeon who knows what kind of surgical procedure he is planning to do and therefore what kind of incision he is going to take on this patient, he is the one who should be doing the biopsy procedure. Coming to histopathology of bone tumors, it is very important to know that the pathologic diagnosis of primary bone tumors is particularly challenging. It is because these are very rare diseases and many pathologists have insufficient experience with these conditions. It is necessary for the pathologist to integrate the clinical, laboratory and imaging findings in the final diagnosis. It is not just what you see under the microscope. You have to see whether it is consistent with the clinical and imaging findings of that particular condition. So it is generally recommended that you should send tissue to an experienced musculoskeletal pathologist. At the same time, you should provide a detailed note of the clinical and radiological findings with your impression about the likely differential diagnosis to the pathologist. It is important for us to know that diagnosis of any musculoskeletal tumor is not the imaging finding or the pathology findings or the clinical findings in isolation. It is about integration of the imaging findings, the pathology findings and the clinical findings, all of which should converge to a specific diagnosis. That is when we know what we are dealing with. So it is not just a single report of the pathologist or the MRI report of a radiologist or the impression of a clinician. Diagnosis is reached when all of them converge to a single entity. Next, we come to staging. So, in any malignant condition, we want to know whether the disease is localized or metastatic. This is done with bone scan along with HRCT of the chest to look for any skeletal metastasis and pulmonary metastasis. This is because almost 97 to 98% of sarcoma metastasize to either the lung majority of cases or to some extent to the bone. It rarely goes to any other organ or tissue. Nowadays, PET CT scan has often come to replace these the bone scan and HRCT chest. So in a lot of centers, PET CT scan is the modality of staging. In some cases, bone marrow biopsy may be done, like in Ewing sarcoma, multiple myeloma, and lymphoma. When it comes to bone scan, it is the technetium 99M methyl diphosphonate or MDP, which is used as the radiopharmaceutical, which helps us in basically screening the entire skeletal system for bone lesions. It will help us identify whether a particular lesion is affecting a single site in the skeletal system or whether it is affecting multiple sites. So whether a lesion is monostotic, polyostotic, or whether it is some form of metastatic disease. So it has a very also an important role in localizing small lesions. So very typically in identifying osteoid osteoma, especially in the axial skeleton, which is not always visible on radiography because of the very small size of this particular condition. So that's where bone scan can be useful. It has got a very high sensitivity, however, its specificity is very low. So it can detect very small lesions, but it really doesn't tell us what it is detecting. So in most instances, it cannot also distinguish between any benign lesion from a malignant tumor. There are three bone scans that we see. The one on the left shows a normal bone scan where we see a symmetric uptake. It is basically one from the front and one from the back of the same individual, but it shows a symmetric uptake of the radiopharmaceutical in the entire skeletal system. Now, when we come to the right side images, we see asymmetric uptake, increased uptake of the radiopharmaceutical in both these scans, one on the top and one at the bottom. However, we know that these are abnormal scans, but we really don't know what pathology it represents. Just for your information, the one on the top is a patient with polyostotic fibrous dysplasia, which is a benign condition, and one on the bottom is a patient with extensive prostate metastasis. They do look identical on the scan. So it is a very sensitive investigation, but it really doesn't tell us what is causing this abnormal uptake. Coming to PET scan, which is short for positron emission tomography, it uses fluorodeoxyglucose or FDG, which is a glucose molecule labeled with a radiopharmaceutical. It helps in understanding the level of metabolic activity and perfusion in various organ systems and identifying areas of abnormal metabolic activity. It is more sensitive than CT scan and MRI in the detection of primary and metastatic tumors and recurrences after treatment. Again, like bone scan, it has got high sensitivity, however, the specificity is very low. PET scan for the workup of musculoskeletal neoplasms is now gaining acceptance. It is a very useful investigation in staging of these patients. SUV figures can help identify metastasis with more certainty than bone scan. PET CT can also help in accurate anatomic localization of metastatic lesions in difficult areas or if the lesions are very small, and therefore helps us in targeting them with the CT guided biopsy. HRCT chest has always been the mainstay in the staging of all sarcoma patients. That is because about 90% of the sarcomas metastasize to the lungs. Therefore, HRCT of the chest is a very important investigation in the staging of all primary malignant musculoskeletal tumors. Now, coming to treatment. When indicated, treatment begins only after a firm diagnosis is established and when the staging is complete in the case of malignant tumors. Treatment strategies are based on the type of the lesion, whether it is benign or malignant, exact histological diagnosis of the lesion, anatomical location, and extent of the lesion in that particular location. It depends on the status of the disease, whether it is localized or metastatic. It also depends on the local and systemic issues caused by the lesion and any associated medical general condition of the patient. With that, we come to the end of this particular segment of my presentation on workup of a patient with a suspected bone tumor. Next, I will be speaking on biopsy of bone tumors and briefly covering the staging of bone tumors. Biopsy of bone tumors. Biopsy is a serious business. Though the procedure itself is simple, it has to be conducted in a well thought and responsible manner. An unplanned, poorly executed biopsy procedure can have disastrous consequences on the patient. Most important is to first plan the procedure. First and foremost is important for you to decide, is a biopsy necessary? Once you decide that a biopsy is necessary, you should then figure out where should you biopsy from, which part of the lesion you should sample, where should you place your biopsy incision or approach, and what method should you use. So, why should you first think whether a biopsy is necessary at all or not? Just because there is a bone lesion does not necessarily imply that you need to biopsy it. There are certain lesions which are very clearly benign on imaging and where therapy is not indicated, and therefore there is no need to biopsy. These are typically incidental findings in a asymptomatic patients. These are the so-called do not touch lesions. Similarly, there are certain typical findings in a symptomatic patient with a corroborating history, like those with myositis and stress fracture. In fact, here doing a biopsy can be detrimental because the pathologist may report something very aggressive, and that may push you to take wrong decisions on the treatment of that particular patient. Now, these are some examples of do not touch me lesions. Starting from the top left corner, that is a bone island in a trochanteric region of the proximal femur in an immature skeleton. Next to it is a small enchondroma in the distal end of femur. On the right side, we see a small fibrous cortical defect. Lower down, on the right side, we see a non-ossifying fibroma, and on the extreme left lower corner, we see a patient with fibrous cortical defect in the medial side of the distal tibia. These are very classic diagnoses on imaging. And these are all asymptomatic patients. There is no need to biopsy. You can just ignore them or at best decide to observe them. Now, these are examples of active lesions, but again, they are classic radiological diagnosis. The one on the left is a small osteochondroma in the proximal fibula. Similarly, in the next image is that of an osteochondroma arising from the distal tibia. Next to it is a fusiform dense sclerotic lesion in the radius, which is osteoidostoma. This patient has severe pain, especially night pain. And on the extreme right is again an osteoidostoma in the tibia. We see a eccentric sclerotic lesion in the cortex of the diaphysis of the tibia with possibly a small lytic nidus in it. Now, before you do a biopsy, you should prepare well. You should take a detailed history of the patient and do a thorough clinical evaluation. Do all the relevant imaging and all the relevant blood investigations. Now, why is it important that you need to plan well or prepare well for a biopsy? Well, it is very important to know what are the hazards of a biopsy. This is illustrated very well in two very important papers published by Mankin et al., one in 1982 and the other one in 1996, where they have studied almost 300 to 600 patients who have undergone biopsy, where there were errors in diagnosis in almost 18% of these patients. Biopsy affected the management in almost 18% to 19% of these patients. Biopsy affected the outcome of almost 8 to 10% of this patient and led to unnecessary amputation in almost 3 to 4.5% of these patients. So clearly, biopsy has serious consequences. Now, where you do a biopsy from is very important. Why is it important? For that, you have to understand the importance of the biopsy tract. The biopsy tract is a zone of contamination where the tissue has come in contact with the disease, which is therefore treated as a part of the disease. Bone sarcomas are shown to recur locally from tumor seeding along biopsy tracts after a core needle biopsy. Patients with local recurrence of sarcoma have a lower survival rate even after repeat surgery and adjuvant treatment. So, biopsy tract and immediate surrounding tissue are removed en bloc with the tumor at the time of resection. Where open biopsy of sarcoma is done and the biopsy scar is not removed at final surgery, the local recurrence rate increases almost 5-fold as compared to needle biopsy scars from 7% to 38%. So it is very important to cause minimal local contamination whenever you are doing a biopsy procedure. So it is very important that you should go through prescribed regions or lines of approach only. Don't go from any random direction or any random position or any random location. You should stay away from important neurovascular structures and joints and any potential spaces. Do not go through soft tissue or intramuscular planes or any potential space. Do not open multiple soft tissue planes if you are doing a open biopsy. These are some examples of very badly done biopsy scars. Look at the incision, the size of the incision, and the direction of the incision and the location of the incision. In the left hand side we have a very odd curved shape incision with large hatch marks. For a open biopsy, the incision is too long, the surgical sutures have been taken too wide, and the incision is not straight. In the top right, there is a horizontal incision taken on the calf. That is, a complete no. Whenever it comes to incision on the extremity, it has to be vertical. And the lower one is even worse, where you have a long horizontal incision right over the quadriceps to do a biopsy of the lower and femur lesion. Now this is a disaster. So this is what they end up with. This is a patient who has undergone a biopsy through the popliteal fossa using a horizontal incision for a posterior proximal tibia lesion. And there was no way of salvaging this extremity. This patient had to undergo a bony amputation. When it comes to biopsy procedures, it can be done in two ways. One is with the help of a needle called a needle biopsy, whereas the other procedure is called as an open surgical procedure, also called as open biopsy. Needle biopsy clearly has a lot of advantages. There is very little soft tissue contamination because you are hardly making any cut into the skin or in along the biopsy tract. There is a very small surgical scar which can be easily excised. You can do it under image guidance in the CT scan or in under ultrasound guidance. You can do it as an OPD procedure if the lesion is large enough under local anesthesia. The procedure time is short, it takes a few minutes. The cost is much lower and it is repeatable. The standard bone biopsy needle is called the Jamshedi Swain biopsy needle, also called as the J needle. It has got a cannula, trocar and a pushing stylet. It has a cylindrical needle with a sharp tip which is beveled with a cutting edge. It takes course of 2 to 4 millimeter diameter. The 8 gauge is the regularly used size. In pediatric patient you may use a 11 gauge needle. It is best suited for bone tissue biopsy. Now, true cut biopsy needles are sometimes used for biopsy of musculoskeletal tumors. These are spring loaded core biopsy needles. They are basically used for taking samples from the soft tissue. You can't use it on bone because the tips are delicate and they will just deform, bend, or even break. But if the bone tumor has a large soft tissue mass or you are doing a soft tissue tumor biopsy, these are excellent devices. They give you very good cores. They are easy to use and you can target multiple areas. The disadvantages are that, as I just discussed, as I just said, it is not well suited for bone biopsies because the needles are delicate. However, soft tissue extension of bone lesions can be biopsied. They are slightly more expensive than the Jamshedi needle. Next, you should know where you should biopsy from based on the clinical findings, the X-ray findings and the MRI imaging. So these are the broad guidelines. Sarcomas grow centrifugally, so the periphery is the growing side of the tumor, has the most active and viable cells. That doesn't mean you should sample from the extreme periphery. Periphery means, we generally mean the outer side of a globular mass. The center of the tumor are often necrotic or cystic due to the degeneration that occurs because they outstrip their own blood supply. You should also avoid any calcified areas or ossified areas because they are less likely to have viable tumor cells. And also you should avoid fracture areas because you may sample callous, and that may confuse your pathologist. This is basically a image, a diagrammatic representation of what I meant by sampling the periphery of the lesion. Like you see, this is a destructive lesion in the proximal humerus. The axial imaging shows a central necrotic area, whereas the tumor cells are all in the periphery, which is represented by these crocodiles around a lake in this diagram. So you should sample it from the thicker or denser areas and not from the central necrotic or liquefied area of the lesion. Now, this is a great article on the anatomic guidelines for biopsy. That is, at what anatomic location where you should put the needle from the skin. You can't just sample from anywhere, as I already said. This is a very good article by Patrick Liu et al. You can get it this online in Radiographics 2007. It is available. I just checked it yesterday. And in this, here we are seeing all these various anatomical locations, and those green bands that you see in all these images are the zones from where you can biopsy. So practically all the anatomical locations or sites are represented in this. Like in the top right, top left, you have the proximal femur, so you have to approach it from the lateral side. Then comes the thigh. Most of the thigh can be accessed, or the femur, I mean, the shaft of the femur, you have to access it from the lateral side. But when it comes to the distal end of femur, if the lesion is medial, you can access it from the medial side also. In the tibia, again, the shin area or the subcutaneous area is where you can sample tissue from. In the proximal tibia, you can go from either medial or lateral side. Similarly, for all various anatomical locations, there are representative images in this particular slide. So all those green zones or bands are from where you can safely biopsy. Of course, you can modify this according to the challenge of that particular case, but these are broad general guidelines. Now coming to open biopsy. If at all you want to do open biopsy, or you're compelled to do open biopsy for any reason, like your needle biopsies have failed, or for whatever reason you are pushed to do an open biopsy, you should still follow certain principles. That is, your incision should be along the line of incision of future therapeutic surgical procedure. It cannot be across. So in the extremity, it is always going to be a longitudinal incision. Keep this incision as small as possible. In the extremities, no transverse incisions. And whenever you are doing a biopsy, do not open in layers. So don't raise one layer, the next layer, don't raise flaps, because you are now creating cleavage zones where your tumor cells can percolate once you finish with your biopsy, and that will increase the area of local contamination. Once you are through with the procedure, do a thorough hemostasis. Otherwise, your hematoma will also dissect between the facial planes, and that's where your tumor can spread. Where you feel there is a lot of bleeding or there is a likelihood of collection, you may use a drain, but exit very close to the biopsy wound along the line of incision. And when you're closing, finally use small hatch marks. You don't use stitches very wide away from the suture line, so you from the incision line. So stay close to it and do a good closure. Whenever you are doing in open biopsy of the bone, you must remember that in the diaphysis, or where the lesion is purely intraosseous, or in regions of high stress like the subtrochanteric region, when you make a large window in the bone, you also weaken the bone significantly and put that bone at a high risk of fracture. So subsequent to your procedure, you must protect the bone very well so that this patient doesn't suffer a pathological fracture. Coming to frozen section, it is very important for you to know its benefits and limitations, and therefore its correct application. Frozen section is excellent for evaluation of representative tissue at the time of biopsy. That is to know whether you have sampled tumor tissue or not. That is when you have a doubt of such nature. You don't have to do frozen section every time you do a biopsy, but when you are not sure whether you have sampled tumor tissue, then you can send some of that sample to the frozen section and figure out whether you have sampled tumor tissue. It is also excellent for evaluation of surgical margins and also to rule out metastatic disease in a known setting of malignancy. So, what are the limitations of frozen section? Well, one, it needs a skilled pathologist. Secondly, you cannot process bony specimen in a frozen section. Thirdly, it is not a substitute for regular histopathology. It is advisable that you don't do any irreversible or therapeutic surgical procedure based only on a frozen section diagnosis. Also, you should know that whatever tissue is processed in the frozen section gets damaged, and additional studies on that particular tissue is not possible. So, if you have only sampled a very small fragment of tissue for a primary biopsy, then it is better that you send it all for histopathology rather than send for frozen section, because then further processing of that sample may be a problem. Now, coming to the pathology report, you should know that histopathology report is not the final statement on diagnosis of a bone tumor. It is the final step necessary to formulate a diagnosis. So, if you agree with the reported pathology because it corroborates with the radiological and clinical findings, then you may proceed with treatment. But if you disagree with the reported pathology because it is conflicting with your imaging findings or clinical findings, you must discuss this with the pathologist and the radiologist in a joint meeting. Sometimes you get an ambiguous report where you are not sure only whether it specifies any pathology or there are multiple possibilities that are reported. In that case, don't jump to the decision of treatment. You should again have a discussion with your pathologist and radiologist. If the report says that the sample is non-representative or it reports normal tissue or necrotic tissue, you should assume that the biopsy procedure has failed and you may have to repeat the procedure. Now, why is it important that you need to integrate the clinical, radiological and histological findings to formulate a diagnosis? That is because there are a lot of conditions which mimic each other. There are conditions which are histological mimics, like under the microscope they probably appear similar, like osteosarcoma and osteoblastoma may be confused with each other. Similarly, telangiectatic osteosarcoma and aneurysmal bone cyst may be confused with each other. Callus may look like osteosarcoma, myositis can look like osteosarcoma, brown tumor may be reported as giant cell tumor of bone, synovial sarcoma may be confused with Ewing sarcoma of bone. Similarly, there are radiological mimics like telangiectatic osteosarcoma, aneurysmal bone cyst and giant cell tumor may all look like each other. Low-grade central chondrosarcoma may look like an enchondroma. Eosinophilic granuloma may look like Ewing's sarcoma or some osteomyelitis. There are certain non-neoplastic entities which may be confused with tumors like osteomyelitis, stress fracture, bone infarct, myositis ossificans and brown tumor. So therefore, to reach a diagnosis, you have to integrate the imaging findings, the histological findings and the clinical findings. That's when you reach a diagnosis. Whenever you have an ambiguous report, as we already discussed, you should have a meeting with your radiologist and pathologist, because if your diagnosis is not certain, you cannot decide on treatment. Here you may go for additional tests like immunohistochemistry, electron microscopy or cytogenetics, whatever your pathologist advises. Coming to FNAC, it is important for you to know that it is not a modality of choice in the primary diagnosis of bone tumors. It may be used in identifying recurrent disease or metastatic lesions. It needs a skilled cytopathologist for opining on bone tumors and sarcomas. In the next 3 slides, we will briefly discuss staging of primary bone sarcomas. There are two major staging systems that are followed. One is the MSCS or Enneking staging system of musculoskeletal tumors, and the other is the AJCC or the TNM staging of musculoskeletal tumors. The Enneking staging for malignant musculoskeletal tumors is based on surgical grade, local extent, and presence or absence of metastasis. Based on that, it is divided into 3 stages. stage 1, stage 2, and stage 3. Stage 1 is divided into A and B. Stage 2 is also divided into A and B. Stage 1 is for low grade cancers where the disease is intracompartmental in 1A with no metastasis, and it is extracompartmental in 1B with no metastasis. When it comes to stage 2 diseases, it is for high grade cancers where in 2A it is intracompartmental with no metastasis, and in 2B it is extracompartmental with no metastasis. In stage 3, it can be of any grade and doesn't matter whether it is intra or extra compartmental, but these patients have regional or distant metastasis and therefore they are M1. So in summary, low grade localized tumors are stage 1, high grade localized tumors are stage 2, metastatic tumors regardless of grade are stage 3. Coming to the AJCC staging system or TNM staging system, this TNM staging system mentioned here is for bone cancers of the bones in the arms and legs, chest and ribs, head and face. It doesn't include the cancers which affect the spine and the pelvis, where the staging system has few more additional criteria and it becomes very complicated. Even here, this is a very simplified version of this staging system. The actual staging system has few more criteria which makes it even more complex and difficult for us to grasp and remember. So here is a simplified version. So it talks about the tumor, that is the local extent of disease. T1 means the tumor is low grade and 8 centimeters or less across. T2 means the tumor is high grade, which can be of any size, or a low grade tumor which is more than 8 centimeters across. T3 means there is more than one area of cancer in the same bone, that is, there is a skip lesion. So T3 indicates a skip cancer in the same bone. Next comes a node, which is represented by N. It describes whether the cancer has spread to the lymph nodes. N0 means no regional node spread. N1 means there is spread of cancer to nearby lymph nodes. Metastasis, which is represented by M, describes whether the cancer has spread to a different part of the body. M0 means the cancer has not spread to any other part of the body. M1A means the cancer has spread to the lung. And M1B means the cancer has spread to other areas of the body apart from the lung. Now, depending on that, you may use one of these representative numbers, T1, N0, M0, or T2, M1A, depending on what is the cancer, what is the grade of the cancer, what is the size of the cancer, and whether it has spread to the regional nodes or whether there are metastases. So, to summarize, a patient with a suspected bone tumor should be approached methodically. Any shortcut can have serious consequences. Consider all possibilities, make a list of possible differential diagnoses based on clinical evaluation and imaging studies. Keep possibility of non-neoplastic causes in mind. Unless the diagnosis is 100% certain, do not proceed with treatment. Plan for a needle biopsy, execute it well, send adequate tissue to experienced pathologists, share all relevant clinical and imaging findings. Cross-check the report findings in light of the clinical and imaging findings. If diagnosis is consistent and acceptable, plan next step, which is either staging or treatment. Needle biopsy is preferred over open biopsy, should be done by the treating surgeon. Anakin staging system is simple and helpful in treatment planning. Thank you.